Good morning, everybody. I wonder if you could take your seats as quickly as possible. Behind already. Good morning. Good morning. Sorry, we're already 5 minutes late. We were having a chair crisis, but that's been resolved. And not chair me, chairs those. Okay, so good morning, everybody, and welcome to the conference. If you could just take your seats very quickly. I am your chair for the day. I'm Victoria MacDonald. I am otherwise the health and social care correspondent for Channel 4 News, but I am very delighted to be chairing this today, the GMC Together conference. The theme, as you know, for this conference is supporting a profession under pressure and delivering good care. And I was very pleased myself to see that this was the theme because it's been repeatedly coming up in some of the stories that we health correspondents have been doing over the past year or so, looking at a profession under pressure. The conversations I've had with doctors and nurses and so on recently, you can see the strain as ever, although coping extremely well. The fact that the money wasn't getting through to where it was needed and the increasing number of patients. And actually, interestingly, pressure caused by patients increasingly having ideas about what they want their care to be. And I think one of the discussions we might have later is about when situations like Charlie Gard arise and how the profession deals with that and the patients and what happens when it all breaks down. But I don't want to be too negative. I have also recently seen some good examples of innovation and some really fantastic collaborative work, which has sometimes been lacking in the NHS. There are a few notes to make, but actually, sorry, I don't mean to be too negative, because actually there are a couple of things. I have mentioned the Charlie Gard, and then of course there was this Guardian piece yesterday about the petty tortures of NHS trainee doctors denied leave when their wife has had a miscarriage and so on. So another point for discussion that I think will come up. And goodness knows what's going on in BMA Council, and I'm not sure what we can, if any of you have heard that news, but I'm not saying any more about that. I need to tell you that we are at capacity today. So if you have put yourself down for a workshop, can you please make sure you go to that workshop? You're going to see a little video soon that will explain more of what today is. But the point I have been asked to make you is that today is about being truly interactive and involving you as much as possible. And you have the 11 workshops as well. There is also a board in the exhibition space where you can post your comments and questions for the panel and put your ideas up during the breaks, and the panel will be at 3 o'clock. I would like to thank the conference partners, ECFMG, whose support has made this all possible. There are no fire drills today, so if the fire alarm goes off, please follow the instructions from the fire wardens or leave by the nearest exits, and when you exit the building, please proceed to the assembly point at Alderman's Walk, which reminds me actually of the dream I had last night where I left this building and could not find my way back in for the panel session. So please don't let there be a fire alarm. So before I introduce the first speaker, can we just hear the video? Thank you.
Welcome to this year's GMC conference.
Today, we're here to listen to your ideas for how together we can support a profession under pressure in delivering good care for patients.
As she approaches 100 days as chair of the GMC, Dame Clare Marx shares her early reflections.
Medical leaders play a crucial role in supporting their fellow doctors, so today's keynote speaker, Megan Reitz, focuses on speaking truth to power.
You can get involved in many different sessions today, which cover all areas of our work. Be among the first to experience part of our new training programme, developed to help doctors tackle unprofessional behaviours in the workplace.
Speak with airline captain and Dr. Niall Downey and Anna Rowland from the GMC about how human factors can support a just and learning culture.
Come up with ways to make patient feedback easier for doctors and patients with our revalidation policy manager, Lizzie Leggett.
Test your professionalism
And board game skills,
in our competition-winning workshop.
designed and led by medical students from UCL.
And don't miss our virtual reality experience stand. Try out our VR patient app and explore our VR gallery, which showcases the GMC's 160-year-long history.
We'll see you back here at 3 p.m. for our panel session.
With closing remarks from our Chief Executive, Charlie Massey.
When you have a spare minute, please add a question for the panel to our discussion board.
And help us involve even more people in today's sessions by sharing your thoughts on social media.
Using the hashtag GMCConf.
Whichever sessions you attend today, we're here to listen to you so that together
We can better support a profession under pressure in delivering good care for patients.
Well, on that exciting note, can I now introduce the chair of the GMC, the first woman to hold this post since the GMC was established 160 years ago, which is long overdue. Dame Clare Marx, who became a consultant trauma and orthopaedic surgeon in 1990 and has held a number of posts, not least president of the Royal College of Surgeons during a very exciting time in the NHS, and more recently chair of the Faculty of Medical Leadership and Management until the end of last year. Could you please welcome Dame Clare Marx?
Well, good morning and welcome to our conference. This is my first conference as chairman of the General Medical Council. And we have a really packed day ahead, and I'm looking forward to hearing from you and your insights and your ideas. Now, the mission of the GMC is to protect the public and promote patient safety. And I know that is an aim that is shared by everyone here today. One important way is by supporting doctors to practice medicine safely and effectively, and we need to get better at doing that. Therefore, the theme today is supporting a profession under pressure in delivering good care. Now, just right now, I have to confess that I feel a little bit of pressure because I know we're running a little late and I've got an awful lot to go through in the next 20 minutes. So I hope that you will bear with me. I'm going to be describing the context in which we're working, recognizing the challenges and the huge change that we're all facing. And then I want to discuss what I believe to be a crucial element of successful change and identify a particular issue we should all be thinking about and working on. So here I go. Across the 4 nations of the United Kingdom, we work in a health service which is experiencing increased demand and where that demand is likely to outstrip resource for the foreseeable future. Provision of adequate service geographically and demographically, coupled with workforce issues, are a common thread across each of the UK nations. In parts of England, such as my own home region, East Anglia, early retirements and reduced interest in partnerships have created primary care vacancies such as have never been seen before. In Wales, high numbers of international medical graduates and difficulty in recruitment and retention outside the major metropolitan areas, and the system changes needed to deliver its 10-year plan for health and social care are demanding new ways of delivering service. In Northern Ireland, it's been without a functioning executive for more than 2 years, and there's no minister to progress decisions for the health and social care transformation programme. And last, in Scotland, worries about certain areas being more dependent on EEA and EU doctors are producing uncertainty around the Brexit. I had to get that in. And it's a key factor in their workforce planning. Despite all that, I remain optimistic about the ability of the profession and the wider service to continue to rise to the challenge of delivering good care whilst under pressure. it is getting more difficult, and I don't believe that we have fully tapped into the capability of our clinicians and their potential to lead change. Together with you over the day, we want to explore 3 areas which illustrate some of the challenges ahead and our place in working collaboratively with you all as we attempt to progress solutions. Firstly, there is a context in which we're all working and what it means for doctors delivering care. Then what the GMC is trying to do, or indeed should be trying to do. And lastly, how we can give doctors the tools to navigate the work environment such that they truly enjoy and sustain fulfilling careers. So what are the winds of change in which we're asking doctors to work? Firstly, financial constraints. The NHS budget is growing, but so is demand. Despite recent funding pledges, finances will continue to constrain what can be achieved with the resource available. Secondly, the population is aging. Although life expectancy appears to have reached a plateau, people are living longer with more complex conditions. Taking a snapshot from my own part of the world, Suffolk, it's likely by 2037 we will have 10 times more people living with 2 or more comorbidities, and the number of people living with dementia is forecast to almost double. Then we're experiencing the effects of increasing inequalities, resulting in people making poor health choices. 64% of English adults are now overweight or obese, bringing increased risk of heart diseases or cancer. 1/3 of children are now classified as overweight or obese. All this is coupled with an increasing expectation. Taking Suffolk figures again, the health service there treated 5% more patients overall in secondary care and a 25% increase in A&E attendances over the last 5 years. But when patients were asked for their views in a Health Foundation poll in 2017, only 12% of people thought that the standard of care in the NHS was getting better, and 44% thought it was getting worse. And alongside all of this, the medical profession is still working through the challenges around the erosion of hierarchy, the reality of partnership with patients, and the implications of increased levels of information and new technology. So, from the regulator perspective, we see the number of doctors joining the register increasing in recent years. Currently, there are more than 250,000 holding a license to practice. However, at the moment, we're currently seeing even more people who are wanting to come to the country, an unprecedented interest from international medical graduates to join our register. Overall, the demands of the system are not met by this increasing number of practitioners, although individually they are striving very hard to maintain quality and improve the service that they provide. So against this context that I've just outlined to you, and the constant clamour of the service and the public to do more, can this workforce just do more of the same? Or could it do more by changing? And I suggest to you that change is probably the only way. And that is why, in my view, we need greater clinical leadership. For those of you who might be sceptical, there is now strong evidence that clinical leadership is good for patients. Look at the work by Michael West, showing that good teams working in hospitals are associated with lower mortality, and that good executive leadership is associated with fewer clinical complaints. Then we have the work from the USA, from Serrato and Veronese, showing the positive impact on the quality of health care provided, on the hospital's social programme, and to a lesser extent, financial and operational resources. But this is what is really interesting, the evidence that clinical leadership has also staff benefits, not least the impact of organisational leadership on physician burnout and satisfaction. And this is a really crucial aspect when we hear what our workforce is telling us. The work from the Mayo Clinic with its staff in 2015 showed better medical leadership resulted in decrease in the likelihood of burnout and a marked increase in satisfaction of those staff. Those scores were linked to what I call magic conversations, so great were their benefits. Interestingly, those magic conversations were those between colleagues where clinicians had development conversations and inspired people to do their best, where their conversations empowered people to do the job they were doing and treated them with dignity. And I will come back to that shortly. Before taking up my role, you heard earlier, I was chair of the Faculty of Medical Leadership and Management. And time after time, I heard myself thinking, why is it that unlike almost every other workplace environment, we expect medical leaders to be born rather than having them trained? Now, in my early days as chair of the General Medical Council, I find that this is an organisation that is keen to learn the lessons of the past and to learn from its partners. An organisation that sees the value of working with the profession on issues such as clinical leadership. The depth and breadth of knowledge within the General Medical Council are there to support that sort of work across the 4 countries of the United Kingdom. The time has come for education and coaching of clinical leaders to be taken really seriously. In the same way we train for other skills, we need to develop clinical leaders with the skills, training and support so that they can lead the profession to make the change possible for the benefit of our patients and our citizens. That obviously needs to be a two-way conversation, and I'm looking forward this afternoon to hearing from Dr. Suzanne Shale, who's an expert in organisational and ethics and clinical leadership, who will be sharing key findings from her research into what it's really like being a senior medical leader. And that is one of many workshops which I hope you will all be joining later on in the day. As both a doctor and an associate medical director, I have experienced first-hand the fundamental difference between well-led clinical environments and what they do for the quality of care. Where clinicians are supported to become and to remain good doctors, where unprofessional behaviours are challenged and changed, and where doctors are encouraged to be leaders, patient safety is better. So what is the GMC trying to do? The world we live in it's a changing world. While our role and regulatory functions and high standards that we demand remain the same, we want to spend more time and effort in preparing and supporting doctors to meet those standards. Rather than simply controlling access to the register and investigating when things go wrong, we want to do this in actively supporting professionals to maintain and improve standards of good medical practice. So we are focused on 4 key areas. Firstly, supporting doctors in delivering good medical practice. A big part of that is the development of leadership skills and, crucially, tackling unprofessional behaviours towards colleagues. Anything from basic rudeness to outright bullying and undermining. It is a constant theme of successive health inquiries and a constant in the responses we hear from doctors when we ask them what prevents them in doing their jobs as well as they would wish. Secondly, strengthening collaborations with our regulatory partners across the health service, improving the use of our data and pooling the knowledge that our partners have is central to the work we want to do. Both the hard data that we obtain from complaints and concerns, but also the knowledge that we have within our bodies and the way we get things done when things go wrong. Thirdly, and vitally important, is strengthening our relationship with the profession and the public. We need to start trying more solutions to some of the problems that have the potential to erode public confidence in the profession. There is an understandable frustration, even anger, when repeated public reports demonstrate failure to learn the lessons of how many people knew of but felt unable to tackle poor behaviour that affects the care that patients receive. Finally, we're going to focus on meeting the changing needs of the health service across all the 4 nations of the United Kingdom. So let me now concentrate on the issue of treating our fellow workers with courtesy and dignity, the way we would all like to be treated, and the very special focus of tackling unprofessional behaviours. As part of our strategy of improving prevention of harm, I'm pleased to announce the start of a new pilot that will give doctors the skills and confidence to tackle unprofessional behaviours that affect patient safety and outcomes. All the evidence shows that unprofessional behaviour, such as bullying and undermining, has a direct impact on the safe care of patients, as well as contributing to difficult working environments for doctors and all the other healthcare professionals. In one study alone, 14% of doctors and nurses reported being aware of specific adverse events related to an episode of disruptive behaviour from a colleague. Another more recently put this number at 19%. It is not improving. And if this level of harm was as a result of, say, a drug error, we can just imagine the focus, resource, and energy that would already be ploughed into education and training to improve the system. Our training in professional behaviours and patient safety will be delivered face-to-face with doctors across the United Kingdom. The training will enable doctors to sketch out and discuss their perceptions of unprofessional behaviours, how to identify them, and consider their impact on patient safety. The sessions will also give participants an opportunity to practice the verbal and behavioural skills needed to challenge these behaviours. This work is a direct response from the concerns that we heard during the Medical Professionalism Matters workshops across the United Kingdom in 2015 and 2016, where more than 600 frontline clinicians and health leaders came together to discuss the challenges of professionalism that emerge in daily practice. This really matters. The difficulties in challenging and managing such pervasive behaviours in the workplace are a key theme that emerged from those events. Taking learning from Vanderbilt University in Nashville, we worked with the Royal College of Physicians, Royal College of Surgeons in Edinburgh, and Royal College of Obstetricians and Gynecologists, and developed a training that will be relevant to UK practice. I believe strongly that the best way to protect the public is to have a well-educated, well-supported doctors who work in supportive and supporting environments. It's high time we equip doctors with the means to lead and challenge the behaviours that are detrimental to their efforts and to patient safety. We know that when clinical environments are poorly led, unprofessional behaviours go unchallenged and patient safety suffers. We are acting on the evidence we heard from clinicians and their experiences of unprofessional behaviour to give the doctors the skills and the confidence to lead the changes needed now and in the future, and to help them move from delivering good to great patient care. So what is our goal today and for the future? Our ultimate aim is to create the right environment for safe professional practice and to support a profession under pressure to deliver good care. We want to develop practical tools for developing a just culture for the NHS. In the light of the strong evidence supporting the importance of good clinical leadership, this is a key priority in my new role here at the GMC. But delivering good patient care can't be done in isolation. Working collaboratively with others and making that lead to change is the only way to tackle present and future challenges. That theme of working together with others runs across all our sessions today. Our Education Quality Assurance team will be offering insights into what information is available to you about the organisations training the doctors of today and tomorrow, and it will give you a chance to have your say in how that information is presented to you in the future. We'll also be hearing from speakers from across the world on what it's like to be a medical student or doctor with a long-term health condition or disability. We will be looking into how human factors could improve safety in healthcare and support a just culture that encourages learning. We want to hear about how we can share advice, knowledge, and experience that empowers doctors to speak up. We want your help to shape proposals to revise the patient feedback requirements for revalidation, to make it timely and relevant to the career development of doctors, and to understand your ideas on how to make the process work better for both doctors and their patients. So I'm really looking forward to hearing all of our speakers today and to coming to all the sessions that we've lined up and hearing your views later on in our plenary session. The GMC is one piece of keeping doctors safe and supporting the profession. I'm confident that with your help here today, we can make some progress. Thank you.
Thank you very much, and a very positive way to start off the conference. And I think the emphasis there too is on the interactivity, as we mentioned. We want to hear all your ideas. And of course, the second part of that, or the first part really, was about leadership and about training, which moves very smoothly into our keynote speaker today, Megan Reitz, who is Professor of Leadership and Dialogue at Ashridge Holt International Business School, where she speaks researchers, consults, and supervisors on the intersection of leadership change, dialogue, and mindfulness. Now, if you haven't heard her TED Talk, How Your Power Silences Truth, I highly recommend it. And I was just saying to her earlier that I've been trying to work out how to send it to my editor without him taking it too personally. It is particularly important for those in position of authority, which is obviously not me, to look at how they behave, the signals they send out, and how to be made more self-aware. Now, there will be some time at the end of Megan's speech for some questions, so I hope you've got lots for her. Megan.
Good morning, everybody. It's a privilege to be here. You're expecting me to now talk to you for, at least 45 minutes. I will talk. I will talk with you. But it's more than a little ironic if I kind of talk at you about how to speak up. And we've already talked about today being interactive. And you all know a huge amount about this subject already, because you make choices every day around what to say and what not to, and who to listen to and who not to. So I've got a question for you. Think about something that you would like to say to somebody now. Think about something maybe you feel you should say to somebody at work. If you can't think of anything at work, you can almost certainly think of something at home. So something that you think you should say to somebody, or something that you'd like to say to somebody. This may not be whistleblowing territory. This could be a bit of feedback that you know would be really useful to somebody, but you just haven't quite got round to saying it. Or it might be that something's happening, or the strategy in place is something that you don't quite agree with, you think it could be done a bit better, but you haven't quite managed to say that yet. That sort of thing. Here's a question. What would you like to say? And also, more importantly perhaps, what's affecting your choice about whether to say it or not? That's the bit. So I'm going to ask you to turn to the person next to you and talk about these two questions. I'm dreadfully sorry, it won't be very long, It'll be about 3 minutes each way. But you can describe as much of the situation as you feel comfortable with, but the bit to focus on is what's affecting your choice about whether to say it or whether to stay silent. Over to you. A minute or so left. Okay, pausing there for a second, please. Okay, pausing your conversations, please. But it's not quite over, because I've got another question for you. You get to relax in a second, honestly. So even just then, right, I asked you, share a story. Share something that you need to say, or you want to say, or you should say. And in that moment, whether you noticed it or not, your mind went, shall I share this story? No, I better not share that one. Or I could share this one. Is that an appropriate one to share? Do I want to? So you've just made another choice about what to say and maybe what not to say. So the final question, and literally for 3 minutes or so, what just enabled or disabled you from speaking up just now? Maybe, did you notice a kind of like, I might say that, I might not say that? If so, why? What was that about? And if you just didn't even think about it, and you felt completely free and easy about what you said, what enabled that? Back to you just for another few minutes, please. Let me pause you again, please. Pausing again those conversations. Thank you. Thank you. You can relax now. So, choices. Choices to say something. Choices to stay silent. Choices to listen or perhaps to discount. That's what I've been studying at Ashridge for the last 4 years with my co-researcher, John Higgins. And each one of us in this room and on the live stream have habits of conversation. We kind of have habits about what we find it easy to talk about with particular people and what we tend to not talk so easily about. And we have habits of who we tune into when they speak and habits of people that we tend to tune off when they speak. And our individual habits then sometimes go into collectives, in our teams. We build and develop teams that are used to saying some stuff and not to saying others. Used to listening to some voices and not used to listening to others. And then before you know it, these habits kind of turn into organizational habits, which of course we call culture, patterns of interaction that are happening each day. And so I've been exploring the implications of these conversational habits and what lies behind some of the choices that we make. If I show you those images, I wonder what comes to mind. Normally when I show those images, it takes a while and somebody shouts out, "Scandal!" But there's usually a bit of puzzlement because you might recognize some of them as scandals and not as others. Well, all of them on that screen either have just had a scandal or they're about to have one. That's just to check that you're awake. My research doesn't, unfortunately, go to that level of specificity. But some of these images are obviously there because there were conversational habits that meant that people spoke up but weren't heard or found it very difficult to speak up in the first place. And we know that this is a deep issue within many organisations. So my research is not specifically within the NHS. It includes the NHS, but it goes beyond that. It goes across multiple sectors. In the survey that we've run, and thank you, I think at least a third of you filled in the survey, which I'll go through in just a minute. In that survey, we've got nearly 4,000 responses so far. And we know of the responses that we've got, 40% of people filling in the survey feel that they know or may know something that would harm their organisation. Of those 40%, 20% of them haven't done anything with that knowledge, and they don't know what to do, or they've decided not to say anything. You know, on those statistics, and it may or may not be representative, goodness knows, but on those statistics, about 8% of our workforces have something right now that they know that could damage their organisation, but they haven't spoken about it. So if you look at that in your team, you know, how many members of your team might be sitting there with something, but just can't figure out a way of speaking up about it. Other images on here are up there because they're on the Forbes list of most innovative organisations in the world. So they've got slightly different habits, and they're not perfect, by the way. Each of these organisations have both these sets of habits. But you don't tend to get on the Forbes listing unless there is an ability within your organisation for people to put up their hand and say, "I've got a really crazy idea. Listen to it." Or, "By the way, I think we're doing things wrong. I think we could do them better." So there's habits there that enable people to say that. And that's what we've been looking at. And over the last 4 years, just to point out initially 4 key overall findings that we have. And the first finding is that there's obviously a lot of interest and talk about speaking up. And very frequently I get a knock at the door, usually from a senior leadership team, who come to me and say, "Look, Megan, look, we've got a bit of an issue. They aren't speaking up." It's usually the middle management. They need to speak up more. I just can't, they're not taking responsibility. They're not, you know, we're giving them accountability, but they're not doing it. They're not speaking up. Go and sort them out. And so off I go and I talk to they, and they may say to me, "Yes, but the last person that spoke up has disappeared." Or, "Yes, we have spoken up, but it's made absolutely no difference whatsoever." So speaking up, there's an awful lot of focus on individual bravery and courage around speaking up. And that's phenomenally important, really important. However, speaking up is relational. It's not an individual endeavour. It happens in relationship to an invitation to speak, or the lack of one. Yeah. So we're almost better off focusing on that side sometimes. What we've found is that listening up is a blind or a deaf spot, as we've called it. Yeah, we're not tending to focus in on the quality of listening. We focus a lot on the quality of speaking, but how are we listening? And working with some teams and organisations now, actually, who would almost be better off focusing attention and resources on that side of things rather than the individual bravery. So we notice that. We also notice that we tend to suffer from something called the superiority illusion, and I'll come to this in just a moment. What it means is that we tend to think that we're pretty good at this. You know, luckily, I'm quite good at speaking up and listening up. It's just a shame about the rest of them. Yeah? Or we tap our foot a bit and kind of go, God, the culture around here. Shocking. Until they change, nothing's going to change. And although there's validity in some of that sometimes, very often actually we think we're a little bit better than probably other people think we are. So there's a little bit of work, according to our research, to just enable ourselves to say, okay, whilst I wait for everybody else to change, what could I do? What's my responsibility, capacity to enable other people to speak up around me in particular? And the final thing is that obviously this whole conversation is negotiated via the currency of power, our perceptions of power. So in our choices to speak, we tend to try and figure out, what's my relative status and authority here? What's the rules say about whether I can speak up in this particular environment or whether I should listen to you? So we're consciously or unconsciously navigating and trying to understand power difference. So we've been studying that. We are a business school, so obviously we've come up with a mnemonic. In our interviews and our surveys and ethnographic studies, we've been looking for some of the key choice points, the key issues that affect whether people speak or listen. This is by no means exhaustive, but it does identify the 5 kind of things that crop up again and again. And I just want to take you through what we're calling the truth framework. And we can look at this at the speaking up and at the listening up side. So T stands for trust. How much do you trust the value of your own opinion? You're not going to speak up unless you feel like you've got a decent contribution to make, that you have confidence in your own voice, and you're not going to listen to somebody else unless you trust the value of their opinion. And although, and again, I'll mention this in a bit, although we tend to like to think that we trust other people's opinions, we trust some opinions more than others, which is just as well, by the way. We need to discern, but we possibly need to check out whose voices do we automatically trust, whose do we discount. R stands for risks. So I imagine in your conversations about the choices about whether to speak up, I should think a fair few of you talked about consequences, fear of consequences of one sort or the other. Now, you know, our study is not on whistleblowing, and we've interviewed a number of whistleblowers. And actually, this picture was drawn by Delta 7, who's we're collaborating with. They're facilitators that use art to encourage conversation. One of their members, Julian, drew this last week at the Royal Society of Medicine conference on whistleblowing. You know, there is sometimes there are enormous risks around speaking up. Sometimes it's a matter of career, sometimes it's a matter of lives, and we've certainly talked to a few people where that's been the case. In the vast majority of cases, however, it's not quite as dramatic as this. What we know from our survey, and in fact how you filled it in as well, 2 of the top reasons why people pause in speaking up is 1, the fear of being perceived negatively, and number 2, the fear of upsetting the other person. So we are social animals, yeah? We want to fit in, we want to belong, we don't necessarily want to rock the boat. And a lot of the time we ruminate quite heavily on, no, we might upset the relationship here. And those seemingly mundane decisions can become habitual, and we play it safe. So that's the risks. And I would probably also mention here that we assess risk according to our prior experience. So we tend to go back to what happened last time I said something. And if what happened last time I said something, you got kind of squashed, that will massively impact you, and it might impact you for your whole career. It makes enormous amount of difference. And one area of work that we're doing is working with leaders to notice these moments that could be so easily missed, where they're responding to somebody having had the courage to say something. And it's so easy to kind of discount or ignore or move on. And it can have huge impacts, not only on that person, but on everybody else that's around them. So that's risks. U stands for understanding, and that's around politics. So speaking up and listening up are political acts. And we do that in awareness or not of the power, politics, agendas that we're surrounded by. And the rules of the game, as we call it, you know, the ways of saying things. What are you allowed to say? What are you not allowed to say in this particular situation? One person that we interviewed said that one of the rules of the game was around budgets. His precise comment was, when the word budget is mentioned, the lying begins. He was from the banking sector. And he said, yes, there's a game. You know, you mention a budget and everybody knows how to play the game. You know, you say that, you don't say that. You challenge that, you don't challenge that. And there's lots of these games that happen inside our organisation. And when we're speaking up and listening up, it's quite wise to be a bit savvy about those political games and understand them. T is for titles. So human beings attach titles and labels to each other. And you've attached some titles and labels to me as I walked up here. And you said, you know, woman, probably, British, professor, maybe. I was called that. That's another title. By the way, I love this. About a few weeks ago, I was in a conference and I was asking the audience, you know, what titles? What did they think about titles and were they labelling me? And one lady stuck up her hand straight away and kind of blurted out, well, you walked up and I thought, gosh, she doesn't look like a professor. Which I thought was a lovely example of a label and a picture, something that goes with it. Yeah, you imagine something that associates with that label. And labels matter because they convey relative status and authority. But that's different in different contexts. So in one context, HR, I work a lot with HR. In one context, HR might translate to mean one thing. In another context, it means something else entirely. And that has implications on whether we feel able to speak and whether we listen to other people, the kind of titles and labels. I wonder today, actually, this is one thing that you might take away for the rest of the day. Conferences are classic places to navigate titles, yeah? And labels, and this kind of networking thing that happens. So in this networking bit, you'll have an idea of which labels do I kind of prick my ears up at. And I kind of, oh, I'd quite like to meet them, or I'll definitely listen to them. And which are the ones that you're like, yeah, whatever, move on. Because we have, and don't get me wrong, this is a very useful discernment process that human beings have, thank goodness. Otherwise we'd be here forever, trying to listen to everybody. But can you notice today what labels and titles convey status and authority, and what convey them slightly less? What does that tell you about voice? And finally, I was at a conference last week in South Africa, a mindfulness conference, a conference focused on dialogue about race. I think many people think of mindfulness conferences and imagine this kind of beautiful, peaceful, calm, meditative space. Actually, mindfulness conferences can be the places where you go right to the most challenging conversation that you can have mindfully and thoughtfully. One of the speakers there, David Treleaven, who is a specialist in trauma and the use of mindfulness with trauma, he posed a really interesting question. He said, whose pain do we legitimize and whose do we disappear? And I thought that was really interesting in terms of titles and labels. You could say whose distress or whose challenge do we legitimize, do we listen to, do we act upon? And whose don't we in our organisations? That tells us a lot about what labels convey status and authority. The final one is how to. And this is how do you choose the right words at the right time to the right person in the right environment? And how do you skillfully invite people to speak up in a way that they feel safe, psychologically safe? So one thing is environment I mentioned. We know from our survey that the forum where people are at their most guarded is formal work meetings. What do we do for 23 hours of the working week on average? Formal work meetings. Yeah? We anticipate that people are going to speak up in some of these environments, and yet we know that that's the environment that most people go, okay, better not, better not say anything. So how do we release conversation? How do we open up dialogue, both from the speaking up and also from the listening up perspective? So that's the truth framework. I asked you in the survey your opinions and impressions on speaking up in your own organisations. I just thought you might be interested in seeing some of the collated data from that. I asked you, how often do you think junior, middle and senior employees speak up about malpractice, challenging ways of working and offering ideas? So this is what you responded in terms of, you said, so junior employees, 47% of junior employees would usually or always speak up about malpractice. Obviously, this is just your perceptions. You may be completely deluded. I have no idea. But this is what your collated perceptions are. So you can see there that malpractice is sort of right there at the top, slightly lower responses in terms of challenging ways of working. I asked you, would you speak up about these things? And you said that. So, actually, compared to many groups that I've done, I have worked with groups that have got figures like this, and then the U column is just like 100, 100, 100. It's a bit more obvious. But let me show you if this is not covering you with too much data. In red is the norm data for about 3,500 cross-sector, mainly British European, but international group and what they responded. You can see a few things here. You can see that there's a hierarchy of speaking up. So our perception is that the more senior you are, the more you speak up. Perhaps not overly surprising, but has consequences. You can also see that the junior employees are tending to, in our perceptions, tending to speak up less. What we know from the survey, however, is that they often are the people that know the most in terms of stuff that's going wrong in particular and challenging the ways that we work, because they're at the coalface. So we're calling them, at the moment, we're calling them the secret keepers. We've got junior employees that know stuff, but they're also least likely to speak up about it. So there's something about how we work with that issue and situation. This is an interesting one. We know that the more senior you are, the more likely you are to think that everybody else is speaking up. Okay, so you begin to go into a bit of a bubble of optimism and think that, yeah, no, junior people, yeah, no, they're pretty good around here. Yeah, they are speaking up. And actually, it doesn't appear that they are. So we have to be a little bit careful of that. You can see, obviously, the superiority illusion tends to happen. You know, we tend to think that we're a bit better than most other people. You know, that's what they would do. Of course, I would speak up in that situation. And then we asked you, what would you do if you had a problem? What would happen if you spoke up with a problem? 18% of you thought you'd be rewarded. Nearly 40% of you thought you'd be ignored. And with an idea, that kind of goes up a bit better. You know, you've got 38% of you think that you'd be rewarded for speaking up with that. But you've still got 40% of you that think you'll be ignored. So it's sort of like, why would you? You know, there's what are we doing in response to when people speak? And if their perception and the story is that it's not going to make any difference, they're not going to listen to me, and there's certainly not an upside, it's kind of safer to stay quiet, to be fair, isn't it? So something around how we work with that. We also identified some what we call speak-up traps. So some common reasons why people either don't speak up at all, or if they do speak up, it doesn't go as well as they wanted it to. So here's 3. See which resonates for you. One is we doubt ourselves. So it might be that this came up in some of your conversations. You'll have heard of the imposter syndrome or the imposter experience, I imagine some of you. The voice in your head that says, psst, you know, when are they going to find out I don't know what I'm talking about? Or when are they going to find out that somebody else would be doing this far better than me? Yeah? Oh, that's pleasant. And the imposter voice, so we have interviewed some individuals who need more imposter voice. But mainly people are struggling a little bit with it, and they could do with turning the volume down a tiny bit. Yeah? So there's something about hearing the imposter voice. When that voice comes in, there's something about kind of going, oh, hello, I know you. I've heard you before. Shall I listen to you and stay quiet, or shall I actually kind of go, hang on a second, I'm going to have a bit of an experiment this time. I'm going to do something a bit different. Second speak-up trap is we abdicate. So we don't believe it's our job. And you'll have heard, I'm sure you'll have heard research on bystander theory, you know. Particularly when lots of people know about a situation, we're sometimes even less likely to speak up about it because we just think, well, it's not my role to do that, somebody else should. Or I'm sure that's the boss's job, that's not my job. And abdication can bring teams to their knees and organisations to their knees. After a conference a couple of weeks ago, an NHS conference, I had a senior medical practitioner contact me, and he said, when I was a junior doctor, there was a peer who was really, really tricky, basically a bully, intimidated the people around him. We all knew it. It did not even occur to me that I had any responsibility in telling him about his behaviour. Actually, if I'm honest, all I was thinking was I was quite proud of the fact that I knew how to deal with him quite well and I could kind of get on with him okay. And literally that was that, he said. Fast forward, I think about 3 decades. This gentleman is now in a very senior role, and this peer pops up, but not in a very good way, because a junior colleague is lodging a complaint about his bullying behaviour. And this guy said, okay, now he thought, well, there's nobody else around, it's my job. I have to have this conversation with him. So he kind of got ready for it, in he went, expecting a bit of a fight, gave some feedback to this guy, who burst into tears. Because in his story, he just had not had that conversation. Nobody had actually sat him down and said, this is the effect that you are having on people around you. And he was pretty devastated. The medical chap that told me this story was just saying, gosh, what a difference could I have made if 3 decades ago I'd had a conversation? Maybe, maybe not. Maybe it wouldn't have made any difference. But there's a chance that if I'd not abdicated, I could have changed something, which would have changed this person's career, because now he's facing a formal procedure. But it certainly might have changed, by the sounds of it, an awful lot of other people's lives over the last 10 years. So abdication, you know, we just assume it wouldn't be, why would I say something? Yeah? So we need to question those assumptions when we spot them popping up for us. And the third one is more when we do talk, when we do speak up. I phrase it, we talk to ourselves. We put it in our own language that makes sense for us without necessarily thinking about how we need to phrase it so it lands well over there. Classic in cross-cultural working. You know, I say it in my very British kind of way and, you know, put a bit of sarcasm in there for good measure and wonder why I have completely blank faces looking at me, yeah? Or another good example just recently was an OD change consultant who said he went in to speak to a financial director about the change communications work stream of this transformational project. And the FD sort of looked at him for about 10 minutes and then interrupted him and said, my figures say that we're going bust in 6 months. What do you have to say about that? So another classic example of like, what's it like for that person and talk to that. That's what we need to do a little bit better. So see the other person's point of view. So that's all about speaking up. Listening up. I asked you, what's your impression of how the senior people in your organisation listen? How often do they listen to malpractice, challenging ways of working and offering ideas? This is what you said. You said 73% of those senior to you would usually or always listen to malpractice if you were saying something about malpractice. I asked you whether you would listen. So luckily we're all fine in this room. This is the norm data. So again, we can kind of see this, you know, it may be a very correct perception that other senior people are, you know, far worse than we are at listening. We do know that there's trend. As I said, we do know that as you get more senior, you tend to think people are speaking up. I don't know whether that has also something to do with it. But we need to just be a little bit critical on this. You know, if I wasn't to be listening up as well as I think I listen up, what would be going on there? Can we ask ourselves those questions? And listening up traps, if you have listened to the TEDx talk, you'll have seen these three. These are the ones that I focus on in that. The first is we forget how scary we are. So we really do very often genuinely believe we're approachable. And particularly if we've had various senior labels planted on us as we've gone through our career, we still feel like we're, 20 and kind of approachable and lovely. And then we wonder why people are pausing and coming to us. So who might find you a little bit scary? And if you're sat there thinking, come off it, nobody's going to think I'm scary. I think everybody else is scary, but nobody's going to think I am. Somebody will. Even if it's because you appear to be confident, or even because you are well networked and know other people. It can be for small reasons, but small things matter and they affect whether people speak up and whether you get to hear what they have to say. So we need to empathise with others in that. The second one is we don't question our little list of whose opinion counts. And as you may have heard, this is from an interview with the chief executive who was very passionate about diversity and inclusion, and then said, but I do have my little list of the people that fit and the people that don't. And of course, we all have a list. We all have our lists about who fits and who doesn't, and who we'll listen to and who we don't. And that goes back to this labelling. I asked you whether race, gender, job title, and age affected the way that you listened to other people. 81% of you says that race never or rarely affects how you listen to others. 86% of you said that gender does not affect the way that you listen to others. 58% of you said job title, never or rarely. 68% of you said that age never or rarely affects how you listen. The thing is, it does. It absolutely does, because of unconscious bias. It's not the same. We may really not want it to. We may be passionately active in reducing discrimination, and we cannot really avoid unconscious bias. So it's possibly a more fruitful exercise to say, how are these labels affecting it? And try and have a dialogue with it, even if it's difficult. And in the survey, not in this group, but somebody else, to the extent that somebody filled in the survey and the comment was, I'm offended at this question. So we've got to kind of just open that one up a bit. Finally, we've got a question on the list. Finally, we send shut up signals, not speak up signals. I'm looking for a shut up signal to be sent to me any second. And a phrase that my colleague says is, know your face. Do you know what your face is communicating right now? And some of us have a sort of thinking face, don't we, that is like that. But other people don't know it's your thinking face. Okay, they're assuming that you're a little bit intimidating. So do you know what this kit is communicating at any one time? So finally, I'd say two areas that we're working with, in particular with teams and organisations, to try and alter conversational habits. One is around mindfulness. So you'll spot that this is the kind of advice in relation to the traps. All of this advice relies on your capacity for present moment awareness rather than autopilot. Habits are autopilot reactions. If you're going to alter the way that you speak or listen, you have to have a moment of going, oh, I'm just about to do that thing again. I'm actually going to alter it. And other research that we've done at Ashridge would suggest that you can train to a degree, and there's lots of buts, and you do have to practice loads. You can train your capacity for this present moment awareness, which can in turn alter conversations. We also do a lot of action inquiry conversations. So we'll get groups together to talk about conversational habits, but not just a one-off. You can't do it just a one-off. You've got to keep doing it. So I'm afraid to say the bad news is to change conversational habits takes prioritization, persistence, and a hell of a lot of patience, because it doesn't happen quickly. So in summary, speaking up and listening up, you know this, but they're personal and organizational imperatives. It's relational, so as well as the individual courage bit, can we focus more on how we listen? How could we really invite people around us to speak up better? Changing habits is, I'm afraid, no mean feat. We need to interrupt our automatic pilot. And there are some methods that are looking quite promising in sort of trying to change culture, but I'm afraid it's not an easy task. So I'll leave that slide up, which is some resources that are available. And I'm very, very happy to hear your questions now, but knowing the logistics here, if you don't get to ask a question, please grab me today or just contact me. I am humbly aware that keynote speeches are restricted in their capacity to alter culture. But I do hope that maybe this might stimulate a few more different conversations today and perhaps beyond. And who knows, you know, some of those conversations may in themselves then lead to change. Thank you very much. Thank you.
I don't see how it could not stimulate conversation and hopefully some change, because the NHS could do in places with some of that. Now there are some roving mics, and if you have some questions, put your hands up, and there's one just here. And
this is usually the ironic bit where I've talked about speaking up and nobody says
yes,
a word.
Don't worry, I'm prepared.
Thank you very much.
Yes, we can hear you.
Is it on?
Yes.
Ramesh Mehta from Bapio. Brilliant, yes, stimulating. You said some people are used to listen to some and not to others.
Yeah.
Now, this is very common in my experience. And you then also mentioned later on about unconscious bias, which is so common. Now, how do you suggest to get over it? Because you correctly also said that it becomes culture. And how do you change this culture?
Yeah, oh gosh, that's just the $100 question. I would refer you to some of the work that's gone on in Harvard on the implicit association bias and test. And their book, Blind Spot, is a really interesting read on how absolutely tricky it is to alter unconscious bias. And I think it's a long game, yeah? It's not something that you can alter and switch quickly. The first thing I would say is, can we at least have a conversation about it? Because one thing I've discovered is that people are you know, it's just so politically incorrect to even suggest that race and gender, for example, might get in the way. So if we can't even talk about it, we are never going to start to alter it. So that would be one thing, is to be able to inquire into it over a period of time. And the other thing is that we start to actively associate different messages with different forms over time. So, for example, you know, for decades we've associated white male with leader in particular contexts. And we are starting to alter that and alter experiences. But it takes a long time for the brain to kind of go, oh, okay, it doesn't necessarily mean that. So I think I'm not a specialist in unconscious bias, but I certainly focus on how can we start having conversations about what labels and titles mean stuff in this organisation, because then at least we can start figuring out together how we start to make those associations differently. It's a great question, thank you.
Another question over here.
Thank you very much, Megan. I'm Deirdre Kelly. I'm a paediatrician and I'm a registered member of the GMC. On our table, we were discussing challenge and speaking up. And we wondered if there was a generational change in attitude to speaking up and taking challenge. You've shown us very clearly there's a hierarchical change, but do you think there's a generational one? Do you think the young will become better at it or worse at it?
We have looked at age and millennials in our survey and whether that shows anything. We can't really separate that from the fact that we know that lower down the hierarchy people don't speak up so much. It's showing that millennials are staying quiet. So it does slightly dispute some of the stories that we hear about millennials being prepared to go into the workplace and say whatever they like. We're not seeing that in the survey, particularly at the moment. I remember I was on the Leadership in Healthcare conference. Nicola Mallard was there from BT, who is their head of consumer experience. And she cracked a joke and she said, you know, we get however many hundreds of, you know, millennials in or new recruits into BT. And there they are, willing with their ideas, ready to speak up. And she said, it takes us about 6 months to squash that out of them. I think she was sort of joking. But there's an important thing in there, is I think that there may be truth in an increased capacity and wanting to voice opinion. But of course, how do we deal with that within the cultural systems that we're in is a really interesting question. So there's sort of quite a lot more to do. At the moment, it's not suggesting that there's a great deal of difference, but more research to be done there. Good question again, thank you.
I heard of a millennial completely disrupting a trust board meeting the other day with her ideas, and the chief executive taking her aside and saying there's another way of expressing that rather than criticising the chair right there and there in your first meeting.
Okay, well that's a good example, because that moment, what he or she does, that chief executive, that's what we need to focus on. Because if that's done really well, that individual will feel able to speak up. If it's done badly, that'll be shut down for perhaps quite a while. Thank you.
Oh, sorry, there's one over here.
Yes,
You've got it.
Yeah, hello.
Yep. My name's Dr. Ahmad. I'm an A&E registrar from Birmingham.
Hello.
And my question's not to do with the organizational listening up, but more in my own personal capacity when on the shop floor I am one of the senior decision makers. And the problem that I have with my door always being open, or
yes.
that's what the sign says. And it's taken a lot of time and effort to always have that welcoming face, trying to get rid of that intimidation that others might have to come and speak to me, because it's for the patients that we're caring for.
Yeah.
But because then that has its toll on your personal life,
Yeah.
you use up all your resilience at work,
Yeah.
and then often you also get overburdened with too many things or too many people wanting a piece of you at the same time.
Yeah.
It's how do you then change from my door is always open to I can deal with this, and this right now, and I will listen to you, but not right now.
Yeah, oh, that's a lovely question as well.
Thank you.
Yes, I've written about the phrase, my door is always open, which is a lovely invitation, but it suggests you're lucky enough to have a door. So I agree with you. It takes a lot of energy to kind of have that welcoming. It's an inconvenient truth that if you're in a position of power, your emotional state is contagious. So, you know, it will, if you are bringing that into your interactions, it makes a lot of difference. However, you're only human, aren't you? So you can't, you know, the suggestion I have is, can we be open about how tricky that is as a leader, and keep coming back to, here is my intention, and I'm so sorry, I'm not gonna live up to it 100% of the time. And now and again, can we have a conversation about whether I'm doing this okay? And when I really muck it up because I've had a horrible day, can I come back to you and say, I totally get what I've just done. Please don't let that put you off next time. So just opening it up and having a conversation and our capacity to be a bit compassionate to ourselves, because it's a very tricky thing to do well. But you have the awareness of it, which again is the crucial foundation. Thank you.
I was just thinking, I have a very scary, grumpy face in repose, and being on camera has trained me to try and look neutral, because otherwise I look like I'm about to, punch Jon Snow out. Or, when normally I'm thinking, oh my God, I've forgotten what I was going to say. Anyway, that is all we have time for now. So can you thank Megan for her absolutely stimulating speech? It is the break now, and then at 11:20 the workshops, and I need to just re-emphasize, please do go to the ones that you've chosen, and back here at 3 for the panel session. Thank you.